Our next speaker is going to be Dr. Fariha Shafi. Dr. Shafi is a general internist and faculty member at the University of Missouri, Kansas City. Welcome.
Thank you.
Tell me, and tell the audience a little bit about your current practice and situation, what you do, how you spend your day, and so on.
All right. So firstly, thank you for this opportunity. And secondly, my current practice is where I've been approximately for the past 15 years. So I'm an academic internist. I practice traditional internal medicine or whatever is closest to traditional internal medicine in primary care settings. So I have outpatient clinics that I do 5.5 days a week. So 5.5 days of half-day clinic. And then I have inpatient rotations for about 2 months out of the year. That's what I do. So in a traditional practice. So that's the clinical practice aspect of it. A big chunk of my job really comes from being a docent. So I'm an academic docent within the University of Missouri, Kansas City system. So at the school, we have the traditional MD program where people have done their 4 years of undergrad and then come from med school. The more well-known program is the 6-year BA/MD combined program. And so what ends up happening is students come in after high school, get admitted into medical school, and then they get assigned to a docent mentor for the entirety of their career at the School of Medicine. And that is the part that I'm mostly involved in. So I have 2 docent teams allocated to me, and I mentor approximately 24 students every year. And in my past 15 years as a docent, I think I've mentored maybe close to 220, 230 students in all different subspecialties that they have gone into. So as far as what my day looks like, I generally start my mornings with my student clinics. So my clinics are run with my student team. We end up seeing patients in a morning half day. And usually in my afternoons, I do a lot of admin work. So that's where I wear a lot of my other hats. I work as the medical director for the medical assistant program within the hospital system that I work for, which is Truman Medical Centers. So a lot of that comes from administration, education, continuing education of medical assistants, and kind of helping with the efficiency buildup, et cetera, of the clinic. The other aspects of my job, the other hat that I wear is that I chair the Diversity, Equity, and Inclusion Council within the School of Medicine. So there's a lot of projects that we work on, a lot of organizations with the school that we partner with. So we try to, make sure that our mission and vision are realized day in and day out. So that's something else that I like to do. And whatever free time I get, which is not a whole lot, but I've really tried to get involved in advocacy in the past few years. So I'm involved in various roles with the Missouri State Medical Association on top of really being very involved with the ACP. So I try to, work on those projects and endeavors. And so that's essentially what my day looks like. So it varies which projects I'm working on and which day will, incorporate what aspects of my hats.
So it sounds like the docent arrangement, excuse me, sounds like the docent arrangement may have changed somewhat since the last time I was there. I recall visiting years ago, and each docent had 12 students, 3 from each of the 4 medical school years, in offices clustered around him or her. How is it that you have 24 as opposed to 12?
I have 2 docent units. I got lucky, I guess. So from the very beginning that I started, it just happened like I started as a docent and one of the docents left. So I was taken in as the fill-in docent for that unit. And then once they were able to hire somebody else left. And I guess I must have done a really good job on managing 2 docent teams at a time. So there finally came a point where I think maybe closer to a decade ago, 5-6 years into it, the other docent team that I had kind of, adopted were like not wanting to let me go. And they said, well, what can we do to make this work with your schedule? And so it finally came I mean, the administrative work was a little bit more, but I was already working with them. So I ended up having these 2 docent units and haven't really felt the need to let go of any of them. So that's how I ended up with 2 sets of kids, as I call them.
That sounds like an awful lot of work. Do you have enough time and support to do that? Do you ever feel like you are sort of verging on burnout from doing so much?
Yeah. So I think I've gone through my cycles of burnout pretty much, every 5 to 6 years. But the beauty of it all is my docent part of the job is what gives me a lot of joy. And I would say is probably the thing that I feel I have most control on to run efficiently, because these are students that are really willing to learn. They want to be efficient. They really, give you purpose in life. So I think that part of my job has not caused so much of a burnout. Now, right around application season, right around residency time and stuff, it does get to be a little challenging because I have to write double the number of recommendation letters, or I have to do, write around twice a year. I have to do double the number of evaluations and double the number of interviews, etc. So the work burden is there. And sometimes it does feel overwhelming. But I would say, the support in the sense of having that understanding that, hey, I have to pace myself so I'm not stressed out at the end of the year. I have to manage my time well. That part of it definitely has helped. And I think the other thing that helps a little bit is, these are students that you set expectations for. And so they really try to work with you. I mean, hopefully it's not like they're waiting till the end of the month to get all their observed physicals and observed H&Ps done and they're pacing themselves. But yeah, sometimes it does get overwhelming, but I think I've figured it out, and hopefully will continue to, because I've survived all this time.
How did you end up doing what you're doing? What path brought you to where you are now?
So interestingly for me, it was mostly my husband. So when we were in Buffalo, I wasn't really, I mean, I knew I wanted to do academic medicine, but I didn't really know that there was such a thing as a docent system. And my first job that I took on was an academic hospitalist, which was at a family medicine program run by UMKC. So it was at Lee's Summit. And I was actually on rounds and these students were rounding with me. And I think this is after the second or the third month of being on the rotation with them. And they were like, well, why haven't you thought about being a docent? You'd be really good. I'm like, what is that? And so I learned more about the system and, what a docent entails, everything from my students. And then I reached out to my boss and I said, is this a possibility? And he's like, well, we don't have any availability right now, but if you're interested, I'll keep you in the back of my mind. And just so happened that, 6 months later, one of the docents had to abruptly leave, and he was like, well, do you think you can fill in till we can finalize if this is what you want to do? So that was my original Gold 6 unit 15 years ago. And I took them over, and I realized that fit exactly into what I wanted to do. I've always enjoyed working with students, residents, but I think, being able to connect at a medical student level where you can have so much of an impact, and, they're so impressionable and they give you so much feedback in the sense of how you can improve yourself as an educator, as a person, as a physician. It kind of keeps you young, and it kind of keeps you motivated and on point, I feel. And so I think as much as I have done or performed as a mentor, I think I have gotten a similar amount of mentoring from my mentees. And yeah, so that's how I kind of figured out my job. It wasn't something that I went searching for. It was something that just happened to be there, and I got introduced to it and felt like I got lucky enough to be in the right place at the right time.
Not everybody watching may know Truman is the successor hospital of Kansas City General, and therefore is a safety net hospital. In your practice, in your clinics, are you seeing patients for whom the residents are the primary caregivers, or are some of the panels entirely your own?
So most of what I see, my panel is entirely my own. Up until about 5, 6 years ago, I used to precept with residents and they had their own panels. But again, I kind of like my continuity. And I think when residency programs switched to the 5+1 or 4+1 pattern, that ability to have that continuity, which is where I kind of found my niche, started to kind of slip away from me. So I moved away from that and I decided to only do clinics with my students. I do run a clinic that's independent faculty practice, which I manage on my own. There are no students involved, so I just see my own patients. But yeah, all the panels are essentially my own, and they kind of become your students' panels because for the 4 years that the students are seeing patients with you, they get quite familiar with them. And so, yeah, we kind of get to take care of our patients as a family.
With you running two docent teams, how does that work? I know that the old model was that the students would accompany you to clinics each of the 4 years. So they began really when they were in what in most medical schools would be the first basic science year. Uh, and yet, with 24 students, how do you work that?
So essentially what ends up happening is the students are split into 2 days. So for example, you might have a docent unit that has clinic Mondays and Tuesdays. So half of the team will come in on a Monday and half of the team will come in on a Tuesday morning. Each student is allocated as a junior senior partner relationship, which is, the beauty of it all is that they all get mentors and big brothers, big sisters early on. So I get allocated to clinics based on what their docent allocation is. So my typical days, I have a Monday morning, a Tuesday morning, a Wednesday morning, and a Friday morning clinic. And these morning clinics are all with my students. So Monday, Tuesday would be my one docent team, and Wednesday, Friday is my other docent team. And then Wednesday afternoon, I'll come and do my independent faculty practice clinic, and every other Friday, I do my independent faculty practice clinic where the students are not involved. So that's essentially how it works. I actually love it because it's given me predictability, because even if I had only one docent unit, I would still only do the two clinics, the Monday morning, Tuesday morning. So the other clinics could be floats, or I could be filling in for people, or, doing any kind of clinic work that would be needed. So this is like at least 4 days out of my week are set, and I can plan my life a little bit ahead and not have that much unpredictability of what my life looks like month to month.
So it sounds like you're quite happy in your current situation. Do you have any second thoughts about subspecialization?
I would say I did try and apply years ago to subspecialize. And to be really honest, I think it was pressure from my dad more so than I really wanted to do it. So he's an internist, and he would always tell me, an internist's life is so difficult and you need to subspecialize and, carve out a niche for yourself. So, to appease him, I was like, all right, I think I'm going to give this a try. If this happens, we'll make it work. If it doesn't, it's a sign from God. So I'll tell you, that's how motivated I was, as I tried one cycle and that was it. But no regrets, because I feel the kind of person I am. I love the totality and the complexity of internal medicine. I love the relationship building. And I don't think that a subspecialty allows you to do that, because it's kind of like, you get carved out in your own niche and you're basically, you super specialize in something, which is awesome. But for me, I think I get bored too easily, and I kind of like to look at a bigger picture. And I think the biggest joy of being in primary care comes from, I'm the patient's go-to person, and it's a lot of pride that I take when, a subspecialist or, patient goes to see somebody and they're like, well, I'm not going to do anything till I talk to my primary care doctor. That gives me a lot of joy that I have had the opportunity to build that trust and that relationship over years, where it matters which way I sway them or what I tell them. And so from that perspective, no regrets ever. I have loved what I do.
Say something about your approach to work-life balance. How do you manage it? How do you manage your work, your family, et cetera, et cetera?
I don't know that anybody has a perfect answer to that, because that's the question that from, the WIMS group that I run and the residents and students that I talk to, that's always the biggest thing, right? How do you find the work-life balance? I think for me, um, assessing what part of my life carries the biggest meaning probably helped me the most, because I feel like a lot of burnout for me came from having different aspects of my my life compete for each other. Did I want to be the best doctor? Did I want to be the best researcher? Did I want to be the best mom? Did I want to be the best daughter? And I think, when you start growing up and you finally are like 29, 30, or maybe even 31, I feel like you start to wisen up a little bit. And I think it came to a point where I realized that I had to figure out which aspect of my life was the most important to me. And for me, unconditionally, it's being a mom. And that did not mean that I could not be an excellent mentor or, an excellent academician. It just meant that I had to stop allowing the competition and figure out life around what I wanted to do most. And once I figured that out, it was really easy. So I think finding the job that actually fits really, really well with what I want to do is awesome. The predictability that I talked about, that has really helped me because I have been able to be a part of my children's lives. I have been able to, you know, go out of town on activities with them or be able to participate in what's happening after school or be a big part of anything that's important to them or where they've wanted their parents to be. The other part of it comes from having, a partner in crime, as I say. Between my husband and I, we both conditionally, have this discussion on how is this going to work best for us because we want to really be a part of our family and a part of our kids' lives when they're growing up. And so for most people, the theory is that, and I don't think it's wrong, that when you're young, those are the most productive years of your life. A lot of people tend to work hard and, and compass like savings and so on and so forth. And maybe we did this backwards. For us, it was like, we want to work hard, we want to do this, but we want to find a job where we can do the family stuff. And then, once the kids are out of the house and they don't need us, we can look at doing other things. And I feel like making your peace with that really helps. The other thing that really helped is my mentor, Dr. Polly, telling me you can have everything in your life. It is possible. You just can't expect to have it all at the same time. You have to try to prioritize what in what part and what aspect of your life carries the most value. And I think starting to look at things from that perspective, that really helped, deal with the burnout or the stressors of I need to do X, Y, and Z. So I think figuring out where I am in what stage of my life and what has the biggest priority, and let's focus on that, whether it's a 6-month plan or a 1-year plan, has really helped to find that work-life balance. It's not still all balanced, but I think it's worked out very well where, we're in a good healthy state, we're in a good mental health state. I'm able to cater to, my family and my other family, which is my students. And I'm available to them pretty much 24/7. So I think that part of it has worked where, after my own family, my own kids and all of that, students are my next priority. So I try to make sure that the next people who have the most access to my time is them. And that's okay. So once that's clear in my mind, there's not a lot of fighting and, feeling the burnout.
When you're not on the inpatient service, are your weekends free?
Yes. Yep. That's one of the biggest blessings. I mean, sometimes we cover weekends for each other if, on inpatient we need something, but that's generally a rarity. But yeah, when I'm not on inpatient, so 8 weeks out of the month is essentially when my weekends are allocated to any kind of call. The rest of the time, our time is our own.
And I assume that makes it uh, easier to plan family vacations and so on. How do you handle that, and how much time do you get away each year?
So we get about 4 weeks of vacation, paid time off, and whatever many working days that is, 20 something. And then depending on how long you've been here, you get a comp day here and there. And then we get approximately 2 weeks of CME, so 10 paid CME days, so adding the weekends. I would say that planning vacations is really easy when your kids are in elementary school, maybe even middle school. Once you're a 2-physician household and your kids are in high school, planning anything is very difficult to manage with our schedules. But, because there is so much time and one of the best parts about being in the same job for 15 years is that everyone becomes like your family. Everyone loves to help each other out and work around our schedules. So I don't think it's ever been that if I've needed time off, anyone said, you can't do this. Like a few years ago, my father-in-law was not doing well, and we ended up having, between the two of us, taking a lot of trips back because our parents are still in India. We ended up having to take a lot of trips back, sometimes at the drop of a hat. And I don't ever remember work or our colleagues ever saying that you can't go home and take care of your parents. And same thing when my mom was not feeling well. I mean, I just woke up one day and I was like, I think my mom's having a stroke. I need to leave. And they're like, go, you do you, take care of your family. We'll figure it out. So that part I feel is really easy to do. And we have been very intentional in making sure, except for the COVID year, that we at least take 2 vacations a year. We try to go visit our parents back in Kashmir, and then the one vacation is just fun. So whether the kids want to go to Europe or whether we want a beach vacation or something, we try to do something where we can all decompress and bond as a family. And those memories are something that are priceless. Can't ever get them any other way.
So, working in an academic in an academic setting in what is functionally a safety net hospital, do you feel you're fairly and adequately compensated?
I don't think fairly inadequately. I'm pretty sure compared to private practice, inadequately compensated, but I wouldn't say fairly inadequately. I do think that in the past few years, there has been a conscious effort of at least getting us up to the 50th percentile on, MGMA or whatever it is that we're following now. I do think that, you know, not knowing where you sit on the compensation scale sometimes is tricky because there's a lot of studies that talk about the discrepancies between female and male physicians, and how all of that interplays, and what people at a different academic ranking make, and how your gender plays into it. So that part of sometimes gets tricky. And I think the other thing is, in academia, I don't know that people often talk about the finances of medicine, which is not necessarily right. I do think that needs to change. But I think in the past few years, there have been consistent attempts at improving the the scale of parity. For example, if you make more RVUs than what you need to generate your salary, we've been in a position where people realize that primary care really works hard. That's where a lot of your referrals in a safety net hospital, et cetera, come from. So to make sure that you are compensated at an average rate as opposed to pennies to the dollar because your primary care, that's something that has been realized, at least in our department. I can't say for every department across the board. And that definitely has helped our compensation structure quite a bit, because a lot of us work really hard, and a lot of us that wear different hats, we do have protected time. So for example, if you're doing a particular job, your time support is brought down. So for a lot of us, we do still end up working very hard and making more reviews. So sometimes that helps offset the huge discrepancy in pay. I mean, by no means are we close to, the actual possible market value, at least when you kind of compensate. I mean, look at the comparisons out there in the real market. But I think slowly it gets there. And I think one of the things we don't do enough is ask. That really helps. Like if you ask, I've been here these many years, or this is my designation. What do you think my salary should be? Can I get a raise? So on and so forth. Sometimes it's as simple as that, but I don't know that we do that enough, because I don't think med school ever prepares us very well enough to have those conversations.
So who's your current dean?
It's Dr. Jackson, Marianne Jackson.
So you've had at least 3 women deans: Marjorie Surridge and Betty Drees, and now Dr. Jackson. Has that made a difference in compensation and in
So the interesting part is, majority of our compensation does not come from the university. And I do think we have had, having deans as women is definitely positive, because a lot of the issues that do revolve around these things are a priority, and there is education, and there are initiatives around it. The issue is that the university is not our employer, where it would be completely different. So the university pays down your support for being a docent, but our salary actually comes from a completely independent situation is called university health physicians. So they don't really have much of a control on what happens to our compensation. They have control over protected time. So I think that's what we bargained for. And generally, that's been pretty decent and pretty good. But yeah, the salary structure does not necessarily come from the university.
So I think many universities have faculty practice plans. Um, your department chair is also a woman, Jill Mormeyer. Is she on does she have input into your compensation? Is she a member of the practice plan board of directors?
Yes.
And so again, I would ask you, do you think that that's made a difference?
I think to some degree it has, and I think again, like I say, it's the conversations that need to be had. Like if you don't bring up something as an issue, people don't really do anything about it. But if you think something is an issue, and for that matter, I think it's great that we have women in leadership. In fact, we might be one of the few places that have so many women in leadership, which is awesome. But I don't necessarily think that impacts a whole bunch. I think it gives the person up in leadership a different perspective and allows them to kind of work towards your cause. But I think we have men within our leadership departments that have continued to advocate for us. I would say, my immediate boss, I feel very comfortable. Like if I have issues and I feel like, hey, is this something that you think needs to be compensated at a different rate? I think I feel pretty comfortable in advocating for myself and going up to a male colleague or a male superior and asking them for it. Yeah, but I would say definitely having women in those realms and in those positions where they can definitely, look at things from that perspective, where research is out there. I mean, it's not something that's new that we're talking about, and presenting it as, a very matter of factual, let's do a project and see where compensation lies, and then kind of go and advocate for equity or equality. I think it makes it easier.
So it sounds like Kansas City was a choice that was driven in part by your joint decision to come to Kansas City, two jobs in the same location. Is that what it was?
Yeah. So
Maybe
both
you
of
could say
us,
something about what based on your experience, what should new residency grads be looking at as questions they should ask in taking their first job?
I think one of the biggest things we forget is looking at the whole package. One of the things that I didn't realize, and this is something that I've been involved in, is the retirement committee, looking at what your benefits look like. So don't look at just the initial number that's, shoved at you as far as this is your salary. Look at the whole package and definitely come prepared. Do your market research, have at least a couple of job offers or, at least a couple of conversations going on. So, that, what is the going market value for what your skill set is and what you're bringing, even if you're comparing the same area or you're comparing a couple of different areas. Definitely look at where you're applying as far as I always call it like places for doctors to work that are considered good, where there's a lot of physician protection laws and wealth protection laws, et cetera. The other thing I would say is when you get in for an interview, find out what the attrition rate is. Find out how often people are leaving and how long people are staying. That truly was one of the things that spoke to us when we came to Kansas City. That plus the fact we came to interview in December, it was 70 degrees. We thought that's how the weather was here all the time. That did not happen the following year. It was a blizzard. But, what was interesting was we came and we interviewed with a lot of people, and those people had already been around 7, 8, 10 years. So, that speaks to, I feel like, the kind of family that people can cultivate around an institution. Because to me, we always figured if you were making a little bit less here versus there, we were two physicians, we'd be okay. But what was really important for us was to be a part of a group that really functioned like a family. And I think some of my longest relationships and truest friends are friends that I've made at work. It truly is my work family. So I think that's really important because that really helps burnout, because you're going to burn out. I feel like no matter, even if you find your most perfect job, things are not always going to be rosy and sunny. But when you're surrounded by people who are out there who care about you, and who want to help you through a lot of these things, that really helps. So find out what the attrition rate is, find out how long people stay, find out how many of their own residents actually want to work for them. That generally says very good things. The other thing we always talk about, especially in women's groups, is always negotiate for more. And more doesn't always have to be in the form of money. More can be in the form of protected time. More can be in the form of, what other support you need, for you to realize what your, potential growth in what you have chosen to do is. There was an attorney who was in one of our women in medicine groups, and she said that if you feel hesitant about having negotiations, there's no harm in hiring an attorney that can do that for you if you're not the kind of person who likes to talk money, which especially happens with a lot of women. So I didn't, when I signed my first contract, I didn't know I could do that. But that's always something important to think about. There are other ways to advocate for yourself. Always hire an attorney and have them go through, each contract line by line. They always tell you this is the generic contract and everybody signs it. Not always true. There are always exceptions. There are always things that you can have written in. So make sure you spend that extra money and have people have a professional read your contract and let you know, what it really means. And then if you have questions, ask. I've always felt like I've had questions day in and day out, whether it's a retirement plan, it's whatever. And I generally get a response within 24 hours. And if you can't find an answer, somebody will be out there. In this stage of internet, it's not really difficult to find an answer. And never accept the first offer. There's always more money on the table. You just, or like I said, not just money, but there's always more that can be worked into a deal. You just have to be prepared to ask for it. And I think that's where a lot of us don't do a very good job. It's not that they're not willing to offer it to you. They're just waiting for you to ask. And I don't think enough of us do.
So you mentioned attrition and turnover as one red flag. Are any others that you can think of?
To me, that's always been the biggest one. If you can't keep people in, then there's something really wrong with the organization. The other thing is, see how many, especially if you're going out for lunch or something, see how people interact with each other. And if there are lots of weird looks and stuff, the subtleties that sometimes do happen. I had gone on a job interview and it was very awkward. This person was trying to present the job in a very positive light, and the other person that was on the other side was like, oh yeah, I just started 3 months ago and I didn't have that experience. I'm still trying to get my desktop. I'm still trying to do this. And so just have your antennas open and on and see how those conversations or how those subtle nonverbal cues happen, because sometimes that's a very good gauge of what might or might not be. The other thing I always tell people is find out, what else there is to support their physicians. With the burnout epidemic, there's a lot of wellness initiatives. Figure out, what those wellness initiatives really mean for your organization. Is it just a phone number that you pick up and call, or are they tracking this information, and what are they doing to support you? So I think all of those things you can pick up in conversations and specifically ask those questions. I think that does really help for you to figure out, is this the right place? The other important piece of information that I always tell people who are going for their first job is if you don't like it, a lot of people don't like their first job. It's okay. Don't feel stressed about it. And it's not a commitment that you're making for life. You just want to make the best decision for you. So you're just making the best decision for yourself at that time. And if in a year or 2 years you realize that's not working, that's okay. Which brings something else up is find out what your non-compete clause is. A lot of the places will tell you that they don't have a non-compete, but it's okay. But you just want to make sure that, their history tells you that it's okay, that if you leave, you can work 10 miles down the road. Because sometimes that's also a suggestive of not maybe a nice or a hostile work environment if their non-competes are very difficult to do. And I think the other thing is nowadays with the internet and news being as open as it is, you want to know how these places are treating physicians. One of the things that you hear day in and day out is, entire subsets of physicians being fired and having covered by mid-level practitioners, so on and so forth. So you want to really research the practices of where you're going to go and what kind of support you can expect from the administration. I think all those factors are important because medicine's changing. It's changing very fast.
And on that subject, as you uh, survey medicine writ large, and recognizing that, as Yogi Berra probably didn't say, predictions are very hard, especially about the future. Uh, what do you see coming down the pike in medicine that will have an impact on the lives of recent residency graduates for good and ill?
Right. So I would say this is the conversation we had as I got off of docent rotation. It was students asking me whether the specialty they choose should be impacted by should they follow their passion or should they follow with what the medical world looks like right now. And I said it has to be both. If are passionate about something, you have earned it to follow that. But medicine is changing very quickly for a lot of, I would say, practices. I mean, there are very few independent practices that have been able to survive, right? The competition of being taken over by giant organizations is essentially something that is very difficult for the average, I would say, primary care practitioner to compete with. Subspecialties might be different, but it's getting difficult. The other thing you're competing against is a lot of legislation where you have to figure out, is your job something where they want one person to supervise a whole bunch of mid-level practitioners, and now you're going to have difficulty finding a job in 10 years? You have to put that at the back of your mind, because medical school education, as we know it, it's a crushing debt, right? I don't think, I mean, there are some schools maybe within the state of Texas, or if you end up going to an in-state medical school where you might not be taking on $250,000 in debt, but the average debt, 275, 280, after you graduate med school, that's a mortgage payment that you're graduating with. You have to realize that the choices that you make are going to impact that. The choices that you make are going to impact your financial freedom. And one of the things that I always tell my students is medicine is going to be a point where you're going to be a physician and something. You're going to need to do that. You're going to figure out that you have to carve out a niche which is very specific to you, where you're not easily replaceable. And that's something that I think, whether you're a physician or an IT professional or whoever you are, I mean, you're competing against information technology and all these other things that are coming on. You have to be on top of your game, and you have to evolve and innovate. And I think that is what you have to do. So I think if you want to do anesthesia, just because, the CRNA movement is up there, it does not mean you cannot be an anesthesiologist, but it does mean that maybe you have to look at becoming an anesthesiologist and have something else, and have a career where this is not your only income stream, or this is not your only thing that you're depending on. Because I mean, if it's not going to be that, it's going to be AI, it's going to be robotics, it's going to be something else, because we are so fast evolving. There is no substitution for the human connection. And I think there is no substitution for experience and education. I mean, you, as somebody who has 12 years of postgraduate knowledge and education, you definitely have an edge. The unfortunate truth is the decision makers are not the people who are in these scientific fields and who see it that way, because it's a business decision, it's a financial decision. So I do think that you have to go into it with your eyes wide open. You do have to go into it with starting to learn the business side of medicine and having a business sense, and realizing that maybe in 10 years, medicine, who knows, I hope I'm wrong, but medicine is not going to be a profession where that is going to be, your step onto financial independence. I just don't think it'll be that way.
Thank you.